Welcome back, everyone. Today we're going to talk about two very important topics. The first, I think, is just important for this class. If we're going to have a class about suicide and learn why people die by suicide, how to prevent suicide, we need to talk about what suicide is and how do we define suicide. So the first part of this, we'll be touching a little bit on that. A lot of it you'll get from your readings. The readings are very strong on this. So a lot of it will come from that, but I want to discuss it a little bit and some of the difficulties that we have with defining suicide. I also want to talk about suicide research, and I know every psych course seems to have a section on research, and a lot of people think it's really boring, but it's a very important topic for suicide for a couple of reasons. One is because, as you'll see, we know relatively little compared to the other top 10 causes of death. We know very, very little about suicide. There's a lot that we don't know. An example of this is if you look at how good clinicians, so actual mental health professionals, are at predicting suicide, we're actually no better than chance. I mean, you'd actually do just as well flipping a coin to determine if someone was going to attempt or die by suicide or not, as by us doing a formal evaluation. Now, that doesn't mean we shouldn't do the evaluation. We absolutely should. We can triage individuals. We can get those into treatment who need treatment. But the field has a long way to go. And so it's good to talk about research, where the needs are, and also where a lot of the difficulties are, because there are a lot of difficulties with doing suicide research, and that's part of the reason why so few people do it. But first, let's talk about what is suicide. So, coming into this class, that probably seemed like a pretty easy answer. But as you get through the readings, especially I think Joyner's reading is really very good with this, you probably found yourself realizing that's a much more difficult question than maybe you initially thought. For instance, suicide bombers. Are suicide bombers, is that a suicide death for the actual bomber? What about people who engage in self-injury? How do we classify that? Is that a suicide attempt? Is it not? So there are a lot of degrees and a lot of, here's another one actually. You have someone who attempts suicide by taking 2 Advil. So it's a suicide method that is not going to be lethal for at least most people. Is that a suicide attempt? So as you can see, it's tricky. So that's part of the reason I assigned the Silverman paper. I do love the Silverman paper, though it is a bit dense. And these are based upon the Silverman paper. And I thought it'd just be good to kind of run through these 3 main classifications that we talked about. So, suicidal ideation. So what suicidal ideation is, if you hear this, it just means suicidal thoughts. These could be passing thoughts, they're the thought, that individuals may have, or they're driving down the freeway thinking, well, what happens if I just, went off the road? It could be very fleeting or passing like that, or it could be very serious. And part of the difference is suicide intent. So what intent is essentially how strongly you desire to die, how much you actually intend to end your life, how seriously are you thinking about it. So I may just have a thought in passing, what would happen if I drove off the freeway, and I don't want to die, I have no intention of dying, I have no intent. And that's very different than having that thought and really wanting to die and thinking, if I did this, what would happen? So intent is very important, especially when we get to assessing suicide risk, which we'll talk about later in this in the class. Intent gets to be very, very important. So suicide attempt is defined as a self-inflicted potentially injurious behavior with a non-fatal outcome for which there is evidence of an intent to die. So let's talk about that example with 2-Advil. So an individual, says that they attempted suicide and they only took 2-Advil. Is it self-inflicted? Is it potentially injurious? Well, possibly. What we usually will look at here is what was the person's belief? Did the person believe that it was, potentially lethal or likely lethal? If the individual believed it to be a likely lethal attempt, even if it was not going to be lethal, that would be a suicide attempt. So often suicide attempt, it's kind of a messy variable to look at because it's very much self-defined. But what you're looking for here is there any suicide intent? So did the individual actually want to end their life? Were they doing this in the hopes of ending their life? And did they believe that what they did had the potential of killing them? If so, that would be a suicide attempt. Now, what about cutting or non-suicidal self-injury? Well, there isn't a intent to die. The individual is, doing something that is definitely self-inflicted and definitely injurious, but there's no intent to die. So that's different. That would not be a suicide attempt because you don't have that intent. And then lastly, suicide or death by suicide is a death caused by a suicide attempt. So that one's a little clearer. Though, again, as Joyner's book shows, it's not as clear as one would think. It's actually estimated that suicide may be underreported by as much as 25% because it is so hard to know. So let's say you have a single driver car accident, so just one person in the car. They drove off a cliff and there are no brake marks. Well, did the individual, was that a suicide? Or did the person fall asleep at the wheel? It's hard to know. So with that will almost always be declared a accident instead of a suicide. And honestly, I think rightfully so, because we just don't know. But there are times where we do know. Either there's a note or we are able to put it together where it's pretty clear that it's a suicide. And those are the ones that, get classified as such. Now, while we're here, I think it's important to talk about terminology a little bit. We know that the way that suicide is presented can affect the way that people react to it, the way people view suicide, and also ultimately affect suicide rates. So I will always say suicide or death by suicide. I don't say someone completed suicide. There are a lot of terms that are used and are still used even by some professionals, but we're really trying to get away from those. Why? Because it has a positive connotation. It's saying that actually, or someone succeeded in a suicide attempt. You hear that sometimes too. By saying that, you're actually saying that the death is a positive thing, and that isn't what we want to reinforce. So with that, we try to take the positive words out when relating to suicide. So I just either say suicide or this individual died by suicide, instead of saying that they completed suicide, which has a positive connotation. So as we mentioned, there are gray areas such as either indirect self-destructive behavior. So that would be, for instance, if you had someone that refused to eat or refused to take a medication that would help them, those are things that are indirect. They're not directly doing it to themselves, but they're withholding something that would be helpful or important for their life. Is that suicidal behavior? It's hard to say. Also, I mentioned non-suicidal self-injury. It looks a lot like a suicide attempt. It's just a question of is there intent. So, long story short, defining suicide is not an easy task. So, epidemiology. So, it's really important to know how prevalent suicide is and to have a little understanding of the rates. Now, I'm going to go into this later on in the semester when we get into differences in ages and some of the biological and physiological factors that affect suicide. But I thought it'd be really important to start out early in the class talking about the prevalence of suicide and some of the predictors just to give you a sense. And to do this, I'm going to do it in a way that I commonly actually present this in person to hopefully illustrate the magnitude of suicide. So, in 2010, there were 38,364 deaths by suicide in the United States. And that sounds like a lot, but people have trouble with big numbers. Politicians know this very well. For instance, between $1 billion and $1 trillion, people struggle with knowing the difference in magnitude between those two numbers, despite it being a huge difference in magnitude. So, with that, it's hard to know how many suicides that is. So, let me compare it with a couple other causes of death. First, with the caveat that I'm not trying to minimize or maximize any specific cause of death. Rather, I present these just to give a frame of reference so you can understand the size of the problem related to other causes of death. So, lightning. You hear about people that die or get hit by lightning. We clear out sports stadiums. We clear out swimming pools. We do a lot of things to prevent people from dying by lightning. And that's a good thing. That's a very important thing. And with that, about 49 people every year die due to being hit by lightning. Fire. Fire, you hear about house fires. Certainly, in the new building codes, I'm pretty sure almost everywhere, you're required to have a fire alarm in every bedroom. So we take great precautions to prevent fire deaths. And there are about 3,195 deaths due to fire every year. Drowning. Drowning is very much the same way. We have lifeguards at pools, lifeguards at the beach, trying to prevent drowning, and it's good because there are about 4,000 people who die by drowning every year. Now, murders. Murders are hard. You hear a lot about murders. They always make the news, of course. But how many murders are there? Well, believe it or not, there are about twice as many suicides as murders. Actually, a little more than twice. And lastly, I present auto accidents. A lot of people know someone who's died in an auto accident. Very common. You hear about it a lot, more than it should. So, how common are auto accident deaths? Well, believe it or not, there are actually more suicides, at least in 2010, and this has been for the last couple of years, than there are deaths in auto accidents. So, that's pretty stunning when you think about it. The difference is you hear a lot more about these causes of death than you do about suicide. So for any of these, if you thought that suicide would be less prevalent, it's probably due to something that we call the availability heuristic, which is we associate the prevalence with how much we hear about something. So you hear a lot about automobile deaths or murders, so you think that they're prevalent. Whereas people don't talk about suicide much. There's a stigma about suicide where people just don't talk about it. And because of that, people don't realize how big of a problem it is. It's actually the 10th leading cause of death in the United States. For Mississippi, we're right in the middle as far as suicide rates. We had the 30th highest suicide rate, and in 2010 we had 388 individuals die by suicide. So it's a problem in Mississippi, it's a problem everywhere. It's something that we need to continue working on, because unfortunately the suicide rate continues to increase. So down here you see the overall national suicide rate, and you can see over the last several years we've had this increase in the suicide rate, whereas it had been stable for quite a few years, but now we're really seeing this increase. And again, I'll get more into age differences later, but just to give you an idea of what's going on, what we see is older adults who have always traditionally had the highest rates, and older adult men still do if you just look within men. Older adults, their rate has been going down, so that's good. But what we see is the baby boomers, that generation, we're really seeing an increase in suicide among that group. I also didn't include them on this draft, but around the college-aged individuals, so 18 to 24, we're seeing an increase there as well. So even though we have this decrease in this very vulnerable group, we've seen an increase in these other groups. Now, I should mention that, someone may at some point put a question on a quiz asking what group has the highest risk of suicide. And the right answer to that would be middle-aged adults. And again, it's one of those things that you just have to know because it was older adults for so long, but just in recent years, we've seen that switch. And it's important to know just because we really do need to focus on looking at these baby boomers and trying to figure out how can we reach out to these individuals and help reduce this risk. So how do we do that? Well, that actually leads in very nicely to suicide research. There's a lot we don't know about suicide. So with that, obviously there's a great need for research to learn how to better predict it, understand it, and prevent it. So there are several different types of suicide research. I'm going to go through several of them and just talk about some of the pros and cons and what they actually look like. Now, I don't have great readings for these, so these will be on your quiz, but it's going to be based upon the video lecture information. So just be sure you take good notes for this section. So I'll talk more about all of these in later slides, but let me just kind of touch on what they are briefly. So in retrospective designs, what you do is you're looking into the past, whereas prospective looks into the future. So if I'm doing a retrospective design, what I'm doing is I'm looking at a sample of people, finding the individuals who died by suicide, and then studying, maybe how they compare to another group of people. So I'm looking into the past in order to do that research. Prospective, I actually follow individuals, so I do an assessment, and I follow them to see who ends up dying by suicide. Now, in some countries, this is easier to do than others. We're in a country that's fairly hard to do this. In some countries, there are, death registers where it's easy to figure out how someone died, and then you can actually say, okay, for this person, this is how they died, and you can do this a little easier. Psychological autopsy, and this is really viewed as one of the gold standard ways of studying suicide. So what this is after someone dies by suicide, the researcher actually goes and interviews their friends, family, loved ones, trying to reconstruct what the person was like before the suicide, what happened right before. Were they struggling with a mental illness? So trying to piece it together from the report of others. So that's what a psychological autopsy is. And then correlational. This is actually what you'll see most commonly in the literature. This is just looking at how variables relate to each other at any given moment. So often what we end up looking at is how do variables relate to suicidal thoughts or a measure of suicide risk. So actually a lot of my research is correlational. I look at how sleep problems are related to suicidal behavior or to suicidal thoughts, and how other aspects of mental health may be associated with suicidal behavior or thoughts. So The gold standard is researching death by suicide. Now, it's hard to do because obviously your participants are dead. So you can't just find people that died by suicide and interview them. So because of that, we end up doing much more elaborate studies in order to study individuals who die by suicide. So as I mentioned, one of the ways that we do this is through prospective research. So what happens is we screen tons of people and then follow them. So usually we follow people for years or even decades. Now, you have to understand, I didn't present the suicide rate earlier, but the suicide rate is roughly 13 individuals per 100,000 every year. So if you have 100,000 people, you can estimate that roughly about 13 will end up dying by suicide in that year. So you can imagine then, you'd have to have a huge number of people that you're following in order to get, a good number of individuals who die by suicide. So, if you needed, let's say you needed 25 individuals who died by suicide, and you're only following from them for a year, you need to assess 200,000 people, and then be able to know how each one of them, whether or not they died and how they died. So it's a huge undertaking. Now, there are reasons to do this. It's a great way to do research. Why? The researcher gets to select the questions that are asked. And you'll see the importance of that later as we talk about different methods of studying suicide. But you get to study what you think is important. You get to pick the questions. And also, it's the actual decedent, the person that ended up dying by suicide, that answered those questions. So you're not relying on someone else's impression of was the individual depressed or things of that nature. You have their actual report. The problem is it takes a ton of people, and here is we're referring to the number of people that are required for a study. It takes massive amounts of people. With that, it has huge costs, both time and money. And also, as I mentioned, with this, you have to determine who actually died by suicide. For some countries, that's easy to do. Here, that's usually harder. There are ways to do it, which we won't go into, but it is more challenging. So a method you see a little bit more often is psychological autopsy. So in a psychological autopsy, again, there's an interview of family members, friends of a decedent after a suicide. And then you pick a comparison group of people who died due to other causes. So that way you can look at, for instance, the prevalence of depression. Was it higher in individuals who died by suicide than those who died at the same age, same gender, but died of a different cause? So the strengths here are, again, the researcher gets to pick which questions are asked. So for me, if I want, studying sleep, I could ask about sleep questions and get the answers I need. Unfortunately, I could not ask the person that died, of course, but that is one of the limitations. Another strength is that you need a lot fewer people, and it takes a lot less time to do this type of study. However, there are several weaknesses, even though this is one of the gold standards and it's a great way of doing research. You often have to rely on coroner's reports, which, again, as I mentioned, 25%, it's estimated that about 25% of suicides are classified as something different because it's not clear that it was a suicide. So, with that, you're only getting those that are very clearly suicides, so that could be biased. You also have to get access to the death records, which may or may not be easy. It depends on where you live, depends on the local laws, depends on the coroner. Some coroners are willing to work with suicide researchers, others aren't. But death records are considered privileged information in many parts of the country, so it's often difficult to get those records. And it still involves a lot of time, effort, and resources, of course, in order to do this type of study. You actually have to, go and interview the family. It can be very difficult because they just lost a loved one. They may not want to talk to a researcher, but so it takes a lot of resources to do. You can also look at treatment records. So this may be where you have a hospital system, let's say the VA. You have all the medical records from these individuals. So you can pick out, the veterans that died by suicide and compare them to a group that did not die by suicide. And look at, for instance, were they diagnosed with depression? Were they taking certain medications? Things of that nature. So the strength here is that it takes a lot less time, a lot less money, and a lot fewer resources. Really, it's just having access to the data, which is in and of itself quite an undertaking, but once you have the data, it's a lot more manageable than the other methods we've discussed so far. However, there are weaknesses. And here, the researcher can't pick the questions. I can look at whether or not they had insomnia diagnoses, but that doesn't mean anyone ever asked them about their sleep. The data were not designed for research. I should mention this is actually a typo. This should be were. Data is plural for those who care. So the data were not designed for research, and so that makes it harder to answer your research questions often. And it's a convenient sample. You're not randomly selecting people. So it's more likely to be biased than the other methods we've talked about. Now you can also do national registries and databases. So there are some large databases, both public and private out there, that allow researchers the benefit of prospective studies without massive investment. So there are databases there. My old advisor used one of these. She used the National Swedish Twin Registry. So for actually well over 100 years now in Sweden, they have been doing this study on twins where they will register them and do all these health checks and look at them across their lifespan. And it's a great data set to look at genetic factors for different things, including suicide. And Sweden is one of those countries where you can actually see how people died, so they have really good data for this. So there are these really big data sets or databases out there. So the strength is that you're able to study suicide death prospectively, which is nice. You're able to see, all the strengths we talked about with prospective research earlier. However, access to the data may be limited. For many of the data sets, including the one I just described, you have to have some affiliation with the study in order to have access. I don't have access to those data. So sometimes it's hard to get the data. The researcher has no control over what was asked. I don't get to ask the question. And also there are many stakeholders. So with that, there may be someone who has already kind of got dibs on that research topic. So it's not something that you can just go in and necessarily get access to. I should also mention, part of the reason I never used that database in my research is since these are often done in other countries, they may not be in English. My advisor actually learned Swedish in order to do this research, so it's a limitation, but it's also a really fantastic resource. So those are all the ways of of studying death by suicide. Now, studying suicide attempts is a little easier, though still challenging, because thankfully suicide attempts, while not nearly as rare as suicide at all, they're about 25 times as prevalent. They're still very challenging to study, but it's easier. So one thing you can do is you can interview suicide attempters. So now this is a significant step removed from a suicide because these are individuals that did not die from their attempt, but it's a very good ancillary. It's only one step removed, so it's not bad. So here, maybe you interview them in the hospital or after discharge or something like that. So some strengths are the researcher gets asked the question. So again, I get to pick the questions that I think are important. It's also a lot more feasible than many other suicide research methods because, again, there are a lot more of them, and the individual hasn't died. So I don't have to go and ask family members instead of asking the individual. I can actually talk to the person that attempted suicide and get the answers from them. However, as I mentioned, it is one step away from a suicide. So what you find may differ from those who died by suicide. And as I mentioned earlier as well, it's also still a very difficult group to get into study. So, because of that, most research, including most of mine, studies suicidal ideation. Again, suicidal ideation are suicidal thoughts. So, suicidal ideation is two significant steps from suicide. So attempts are one significant step. Ideation is a whole nother significant step because here they haven't necessarily ever attempted or even really intended an attempt. It's just that they've had thoughts of suicide. So it is significantly different than suicide. That said, it is one of the best predictors we have of suicidal behavior. So it's still a very important, clinically relevant thing to research. So this research is often correlational. So often we're just looking at one point in time, how are these factors related to each other? But it can be done longitudinally, and it's stronger longitudinally. So the strength here is feasibility. While most people don't have suicidal ideation, actually a very high percentage of people at some point do during their life, at least have the passing thoughts. And so it's a lot easier to find individuals who have had these thoughts. It's a lot easier to do the study because, again, the person's living. So you can ask the questions you want, and so it's just a lot easier with that. But it is very far removed from suicide. And also, dealing with current suicidal ideation has both ethical and logistical concerns you have to deal with. So if I'm doing a study and someone's suicidal, I may have some responsibility in making sure that they get treatment. I need to make sure that they have access to mental health resources or at least referrals, if not more. So you have to consider what are the ethical ramifications of asking certain questions, and how are you going to get a person into treatment if they need to be into treatment. So most of the suicide research you'll see is on suicidal ideation. Most of my research is on suicidal ideation because it's even though it's significantly limited because it is 2 steps away from suicide, it's still a good predictor. And also, it's a really good place to start for a lot of research questions. If something's not associated with suicidal thoughts, it's almost surely not going to be associated with suicide attempts or death by suicide. So it helps you test things out before you go to the great expense, you go forward with an idea that isn't likely to be fruitful scientifically. Now, treatment studies. This is where I assigned that Marshall Linehan paper talking about, there's a great need for treatment studies. And doing treatment studies with suicide is very, very challenging. So, if you've looked at medical studies, you'll likely know that often they use, either a placebo or a weightless control. However, we usually don't do this. We usually don't consider this ethical. Instead, we usually have to use a comparison group with an active treatment. So why is that? Well, whether or not it's ethical is a good debate, and that's a debate for another day. Because think of cancer treatments. They do placebo-controlled trials with cancer treatments, and part of why you do that is because you need to know whether or not the medication works, or if it's just the placebo effect. You have to test medications or treatments, just even psychological treatments, same deal. You got to test them. But also, if you have someone who you know is at risk of suicide, is it ethical to deny them treatment? Probably not. It's at least a very hard sell. So with that, either it's something where you have to make that sell and do something in order to ensure their safety. I've seen studies where they don't do treatment. They're a waitlist control or something like that, where people are waiting to get the treatment, and during that waiting, they're assessed, and that's the control. But they're checked in on very, very frequently, and then referred for treatment if it gets severe or something like that. But it's better to do a comparison group where you have another active treatment. But that makes it harder, because you're competing against another treatment that's designed to help. So it's a challenge. But that's where we say treatment is often compared with treatment as usual. So what that means is treatment as usual is if I went in with suicidal ideation right now to a hospital or to a mental health clinic, whatever they typically do with me, that's treatment as usual. So that's my comparison group. That's my control group. And then I do my treatment, whatever my new novel treatment is, and I see if I have better outcomes than treatment as usual. And then the outcome, of course, could be death by suicide, future suicide attempts, or suicidal ideation. And all of them have limitations. For death by suicide, that'd be an ideal outcome. But again, you need to have a huge study to have enough power to know if it was reducing deaths by suicide. Same with suicide attempts. You need a lot fewer, but you still need to have pretty big groups in order to detect suicide attempts. And also, how are you going to know? Even with death by suicide, it's sometimes hard to figure out, is someone dead or not, or did they just move? And then suicidal ideation is commonly used, but again, it's still 2 steps away from suicide. So there's not a great answer. There's not a necessarily right answer. It just depends on the study. So ethical issues, as I mentioned, early individuals with suicidal ideation, if you have active suicidal ideation, you need to be treated. Especially those who have imminent risk, meaning if an individual can't, it's not clear whether or not they can control those thoughts or those urges, and they feel like they may be in danger, that person needs to be in treatment immediately. There's no question. So with that, if you're assessing current suicidal ideation, it's important to have to have the resources to be able to provide treatment. So, for instance, with where we are in a psychology department, we have it where when participants come in, if they endorse high suicidal ideation, we'll walk them over to the counseling center. We'll help make sure they get into treatment. Or, in some way we'll make sure that they have mental health referrals. But you can't just do nothing. Again, waitlist control groups, I'm probably a little too strong on this because I've seen them used, but they're rarely used because of ethical concerns. Experiments you can't use. I can't randomly assign someone to be in the suicidal group. So you can't use experiments. That doesn't work. And an interesting question that comes up is it even ethical to test a new treatment? So you have a treatment that works. You're testing a treatment that you don't know works. So is it ethical to give someone a treatment that you don't know works when there's something that at least has some empirical support for being effective? It probably is. You just have to argue it, but it's something worth considering. Now, while I'm on this slide, I do want to mention one of the concerns a lot of people have, and there's thankfully been a lot of research about it. People are often concerned that if I ask someone about suicide, that's going to give them the idea. Maybe they had never thought about suicide, but my asking about it made them think, oh, yeah, I should do that, and it may increase suicide risk. Well, there have been several studies that have looked at this. The best, in my opinion, is Madeline Gold's study that show that no, actually asking about suicide does not increase suicide risk. In fact, it may actually even reduce suicide risk. So in Madeline Gold's study, she looked at a large group of high school students and split them into two groups. Half of the group got assessed for suicide, half did not. And what she found is both overall as well as for those who are at high risk, those who are depressed, for instance, asking about suicide did not increase suicide later on. So just by asking, you're not going to increase someone's risk of suicide. So that's important to know. By doing this research, we're not increasing anyone's likelihood of dying by suicide just by asking about suicide. Though we do take a lot of precautions with the research because, again, we want to make sure that people are safe. So, just kind of as a summary, suicide research is really challenging to do. It's hard to find the people to do it. You need a lot of people for some methods. It takes a lot of years of follow-up if you're doing something prospective. Research funding is required for a lot of these. You can't do it without it for a lot of these. And then clinical credentials are often required. For me, I knew I wanted to be a suicide researcher. I didn't feel like I had to be a clinical psychologist. I wasn't what I mean by that is, it wasn't my dream to be a clinical psychologist. It was my dream to study suicide. So I actually became a clinical, I'm in the process, I should say. I'm not technically a clinical psychologist until I'm licensed, which I will be hopefully soon. But I have a PhD in clinical psychology. And why I did that was because I knew that with working with this population, that I needed to have that background. I needed to know about interventions. I needed to know how to treat people in order to best help this group. So having clinical credentials, being a therapist, being a psychologist, being a psychiatrist, is really very helpful in doing this research. And if you're not, it makes it more difficult. It's not impossible. There are a couple well-known suicide researchers who are not clinicians, but it does help to be a clinician.